What is the name?
Very good afternoon. Hi, everyone. This is Dr. Aparna, Clinical Director Neonatology at Cuddles, Kondapur. So I, first of all, wish you all a very happy World Prematurity Day. This is a very momentous occasion for every pediatrician and neonatologist catering to small preterm babies because we are faced with a huge challenge of managing the largest number of preterm births among all countries in the world. So with that in view, we thought today we will talk about our experience with the management of extremely preterm neonates. We know that prematurity, neonatal infections, and perinatal asphyxia account for the largest number of neonatal deaths, and amongst which prematurity is the leading cause for neonatal mortality. And unless and until we address the burden of mortality and morbidities due to prematurity, it would not be possible to mitigate the under 5 mortality. So in the next few minutes, I would like to discuss the management of babies who are born extremely preterm under the 6 following headings as listed here. Firstly, we'll discuss about delivery room care bundle, about the important interventions in the delivery room that can help us in more effective and more optimal management of preterm neonates. We shall then discuss about non-invasive ventilation, followed by early identification and management of a hemodynamically significant PDA, early and aggressive nutrition, the use of bundles and checklists, and lastly, the use of mother's milk feeding and probiotics for preventing NEC. So we'll begin with the delivery room care bundle. I shall be discussing this under 3 broad important headings: cord care, particularly the use of delayed cord clamping and the use of other measures to improve the placentofetal circulation; thermal care bundle in the delivery room with the objective of optimizing the NICU admission temperature; and the use of blended air-oxygen mix for the resuscitation of babies, preterm newborns that are born depressed. The World Health Organization recommends delayed cord clamping for at least 60 seconds for all neonates, both term and preterm, who are born vigorous and who do not require resuscitation at birth. The ILCOR, the International Committee on Resuscitation, also recommends delayed cord clamping, although they recommend a delay of at least 30 to 60 seconds in those neonates who do not require resuscitation. Now, this important intervention is associated with numerous physiological benefits. It improves circulatory and hemodynamic stability in term and preterm neonates, particularly in preterm neonates who are at high risk for transitional circulation and the need for inotropes. It has been seen that delayed cord clamping can improve circulating blood volumes by up to 20 to 30 ml per kg volume. And this results into better circulatory stability and lesser requirement for the need or use of inotropes. The other advantages that are associated with delayed cord clamping include a decrease in the risk for intraventricular bleeds, intraventricular hemorrhage, particularly the severe forms of IVH are found to be lesser when one performs delayed cord clamping. There is better respiratory stability, better transition resulting in decreased need for resuscitation, decreased need for positive pressure ventilation. It results in improved iron stores as well as hematocrit during the first few months. And the effects are seen until 4 to 6 months in neonates, resulting in lesser need for blood transfusions and the transfusion-associated complications such as necrotizing enterocolitis, infections, GVHD, etc. And all these benefits to put together has been found to translate into lesser all-cause mortality among preterm neonates in one large trial, the Australian placental transfusion trial found that there was a decrease in all-cause preterm neonatal mortality as well because of this one single intervention. The longer the delay in the cord clamping has been found to result in greater improvement in the circulating blood volume. There are a couple of concerns with delayed cord clamping, particularly the increase in symptomatic polycythemia. as well as neonatal jaundice because of the increase in the RBC load. But both these morbidities have not found to translate into a greater need for interventions. So although there is an increase in the neonatal hematocrit, it doesn't translate into increased need for partial exchange transfusion for symptomatic polycythemia. And likewise, although there is an increase in the neonatal serum bilirubin levels by around 1 milligrams per deciliter, this also doesn't necessitate an increase in interventions for jaundice in the form of double volume exchange transfusion. All these benefits put together also are likely to benefit in better long-term neurological outcomes. Although only one study looked into this outcome and did find that there was an increase in myelin content in the developing brain and could potentially improve the fine motor development at 4 years of age. So this slide summarizes some of the benefits of delayed cord clamping. One important positive note is that in mothers, it doesn't result in increase in any of the harms. Particularly, there is no increase in postpartum hemorrhage and the use of uterotonic agents like oxytocin, or increase in maternal anemia because of delay in cord clamping. So this is one of the important concerns that obstetricians are likely to have. In term neonates, the use of delayed cord clamping translates into increased hemoglobin by around 2 grams per deciliter and higher ferritin levels that are sustained until 10 weeks of postnatal age and may improve cognition. In preterm neonates, we have discussed most of the benefits, particularly decrease in the need for blood transfusions, 40% reduction in the incidence of intraventricular hemorrhage, and a similar reduction in the incidence of necrotizing enterocolitis. So for all practical purposes, delayed cord clamping can be performed by placing the baby at the level of the introitus, and generally this is managed by placing the baby over the mother's abdomen after a vaginal birth, or by placing the baby over the chest in case of a cesarean section, and by applying the cord clamp after a delay of at least 60 seconds, which is something that is carefully monitored by one dedicated person in the healthcare provider's team. And as of now, this is to be provided to every baby who is not born depressed or who does not require resuscitation at birth. We at KIMS Cuddles NICU at Kondapur, we performed a quality improvement project which spanned over a period of around 5 months. And we tried to implement a series of PDSA cycles, plan, do, study, act cycles, to improve the implementation of delayed cord clamping. And we found that by using these interventions, which included having regular teaching sessions, particularly for the nurses from the labor room, having pictorial displays or posters at all delivery points, having reminders about performing delayed cord clamping in the WhatsApp groups for nurses and the OBG doctors, and by having a dedicated timekeeper, having a clock with a seconds hand at all the delivery room as well as the operation theaters, and by ensuring better transition of temperature or euthermia of babies who were provided delayed cord clamping by making sure that the OT temperature was maintained between 25 to 28 degrees Celsius. All these interventions were found to result in an improvement in compliance to the intervention, starting from the baseline rate, which was 35%, to as much as 86% during the quality improvement study. The second most important intervention when it comes to the delivery room bundle is the use of polyethylene or plastic wraps in the care of very preterm neonates less than 32 weeks, which is used to wrap the baby as soon as the preterm newborn is born without even drying the baby. This wrap, as you can see, covers the entire body surface area of the newborn, including the scalp, and leaves a small space for the provision of positive pressure ventilation if required, and some access to the umbilical cord if umbilical cannulation and the use of intravenous boluses may be required in the delivery room. Now, how does this help? The plastic wrap effectively reduces insensible water losses and results in the improvement in admission temperature by around 0.7 degrees Celsius, and has been also found to translate into absolute reduction in the incidence of admission hypothermia in neonatal units. And we performed another QI project on the implementation of the use of polythene wraps or the thermal care bundle in all preterm neonates below 32 weeks in our unit. And the systematic implementation of the quality improvement package that included educating nurses the use of pre-warmed warmer, which was facilitated by switching on the warmer a good 20 minutes before the arrival of the baby, and the use of plastic wraps and optimization of the OT temperature to 25 to 28 degrees Celsius resulted in improvement in the mean admission temperature from the baseline mean of 35.4 plus or minus initial phase to as much as 36.6 plus or minus 0.7 degrees centigrade in the last phase of the QI project. The third important intervention included the administration of blended air oxygen. And this is based out of the rationale that using low or controlled FiO2 of 21 to 30% oxygen concentration for the resuscitation or ventilation of preterm neonates below 35 weeks who required resuscitation is associated with a lesser risk of free radical associated diseases like ROP and bronchopulmonary dysplasia. It is shown that an FiO2 more than 65% in the delivery room is definitely not recommended, and we need to titrate oxygen concentrations in order to achieve a concentration between 21 to 30% at the initiation, and this could be titrated up in case the baby's minute-specific saturations are below the target range. So oxygen concentrations should be continuously titrated to achieve preductal saturations that reach these interquartile, these ranges based on the minute after birth. And this is only possible and only achievable by the use of blenders in the delivery room, which are connectable to air and oxygen points, and where we can achieve the titration of exact concentration of FiO2 that is being delivered for the preterm baby. So having discussed these three important interventions that are doable in the delivery room in the form of cord care, delayed cord clamping, the use of blended air oxygen mix for providing positive pressure ventilation, and the use of a thermal care bundle that includes the use of polythene wraps, the use of pre-warmed warmers and stockinette caps, and immediate wrapping of the baby in order to optimize the admission temperature. So we have discussed these aspects of the delivery room care bundle, and we now move on to the second important aspect of preterm care in the form of respiratory support. And here we shall discuss about the growing role of non-invasive ventilation in providing respiratory support for preterm newborns. So we do all realize that the use of NIV modes, particularly bubble CPAP, humidified high flow nasal cannula, and non-invasive or nasal intermittent mandatory ventilation, all three modes which are broadly clubbed into NIV or non-invasive ventilation, form an important bridge between nasal cannula oxygen, which is the crude delivery of 100% concentrated oxygen by means of a nasal prong, and the invasive ventilation on the other extreme. The use of NIV modes, particularly with the advent of the popularity of CPAP, bubble CPAP, has definitely been found to improve BPD-free survival, as has been evidenced in an often quoted study which compared BPD rates across centers in the United States. And it was found at the Columbia Hospital in New York City, which had one of the highest rates of utilization of underwater bubble CPAP, was a unit which was found to have the least incidence of bronchopulmonary dysplasia. So when everyone went back and audited as to why this unit managed to achieve the least incidence of BPD, it was found that the unit had a much increased acceptance of bubble CPAP. Now we have been able to expand the armamentarium of NIV to HHH-FNC, humidified heated high flow nasal cannula, which has been found to be non-inferior to CPAP and has been found to be a tangible alternative to CPAP in the post-extubation respiratory support and in weaning from CPAP. And of course, NIMV, which has been used for rescuing babies with recurrent apnea or poor respiratory drive post-extubation. Now we'll begin with CPAP, which is the most studied and the most well-known of the NIV modes. We know that CPAP physiologically helps by preventing the collapse of marginally stable alveoli by increasing functional residual capacity at a volume which is above the closing volume. It also stabilizes the chest wall and hence reduces the incidence of obstructive apneas, and also reduces airway resistance and hence the work of breathing. It stretches the lung and the upper airway vessels by which it stimulates the stretch receptors in the lung. Indirectly, these receptors are found to be responsible for obstructive and central apneas, and hence by stretching the stretch receptors that are present in the lung interstitium, CPAP also reduces the incidence of obstructive and central apneas. By all these measures, CPAP improves the gas exchange and improves VQ mismatch, ventilation perfusion mismatch, and results in lesser intrapulmonary shunting, lowering the pulmonary vascular resistance. Now, despite all the physiological benefits of CPAP, CPAP was still not popular until the beginning of the early 2000s, or the beginning of the 21st century. There was a lot of skepticism whether CPAP would be effective in managing the extremely low birth weight babies who were traditionally being managed with mechanical ventilation. So it was the large Australian study of by Colin Morley and his team, the COIN study, which looked into the comparison of CPAP versus invasive intubation and surfactant administration among 610 extremely preterm neonates born between the gestational ages 25 and 28 plus 6 weeks of gestational age. And this study could demonstrate that either use of CPAP or intubation resulted in similar incidence of the combined outcome of death or bronchopulmonary dysplasia, whereas CPAP was associated with slightly higher incidence of pneumothorax, 9% versus 3% in the intubation arm. But this study gave tremendous confidence that the use of CPAP was a safe and effective and feasible alternative to the routine use of mechanical intubation, mechanical ventilation following intubation, even among extremely preterm neonates. Subsequent studies, including the support trial from the United States, which included a larger population number of preterm neonates, 1,316 preterm neonates between 24 to 27 weeks of gestational age, and the Vermont-Oxford network study that included preterm neonates between 26 and 29 weeks of gestational age, further demonstrated what COIN study had already demonstrated, that either use of CPAP versus the use of intubation followed by mechanical ventilation among extremely preterm neonates resulted in comparable incidence of the combined outcome of death or bronchopulmonary dysplasia. So with all these studies, it was demonstrated that CPAP is not only feasible, but is equally effective as intubation and ventilation as the initial mode of respiratory support. And the use of CPAP could prevent intubation and could prevent the need for surfactant administration in up to 50% of extremely preterm neonates. So there was a need for identifying those newborns who would have early CPAP failure and who may require subsequent intubation and mechanical ventilation. This has now been endorsed by the national guideline by the National Neonatal Forum, CPG Clinical Practice Guidelines, which recommends that, which gives a strong recommendation based on moderate degree or certainty of evidence that extremely preterm neonates with gestational ages should not be routinely intubated in the delivery room, and intubation and ventilation should only be reserved for those neonates with severe perinatal asphyxia requiring resuscitation. So which means that in most other preterm neonates, including neonates less than 28 weeks who are not asphyxiated, CPAP remains an effective mode of respiratory support, initial respiratory support. Now that we are convinced and we have enough evidence for the use of CPAP in extremely preterm neonates, what are the different types of CPAP delivery systems and which one is more advantageous? So broadly, based on the type of gas flow that is used in CPAP systems, you can divide them into constant flow or variable flow systems. In constant flow CPAP systems, the flow is set by the clinician at a constant number, and the pressure is a function of the resistance that is being offered, either in the form of an underwater seal in the underwater bubble CPAP system, or it could be offered by an expiratory valve in ventilator CPAP. So the flow is constant and the pressure can be regulated by the clinician by increasing the depth of immersion of the expiratory tubing in bubble CPAP or by increasing the resistance offered by the expiratory valve in ventilator CPAP. In variable flow systems, such as infant flow driver CPAP, the flow is set by the clinician, but the fluidic flip mechanism, which is because of the one limb of CPAP which is open to the atmosphere, the fluidic flip mechanism allows the flow to vary between inspiration and expiration, and hence constant pressure is generated. So in order to understand the variable flow systems, where we would have an open limb wherein additional flow can be entrailed during inspiration, which is called as Venturi effect or Bernoulli's phenomenon. And during expiration, some of the gas flow or the bias flow is kind of redirected back into the open limb into the atmosphere, which is called as Coanda effect, manages to vary the flow to a higher flow during inspiration and to a lower flow during expiration. And this variation is believed to reduce the infant's work of breathing. So the figure on the left demonstrates bubble CPAP, whereas the figure on the right demonstrates one of the ventilators that can be used to deliver CPAP. The ventilator CPAP uses the expiratory valve of the ventilator to provide resistance during expiration, which is used for delivering positive end expiratory pressure. So having discussed the different CPAP systems, there is knowing that there is not much of difference in the efficacy of one system versus the other. And for most practical reasons and for feasibility advantage, most of us prefer to use the bubble CPAP, which is one of the modes of constant flow CPAP. We now move on to the discussion of CPAP interfaces. Now, we have numerous types of the newer CPAP interfaces, starting from the single prong and the more often used short binasal prongs, as you can see in the picture of the argel prongs in the center, versus the nasal masks that are used more and more now for delivering CPAP. These are some randomized controlled trials that compared the use of CPAP masks versus prongs for delivering bubble CPAP, and the studies concluded in slight difference from each other. Some of them concluding that the use of mask was found to be clearly advantageous when compared to the use of prongs, as seen with the 2012 study of Chiron. And some concluding that both the interfaces were found to have comparable efficacy. So whatever interface we choose, either a short binasal prongs or a nasal mask, it is very important to ensure that there is adequate monitoring by ensuring that the appropriate size of prongs is chosen and the prongs are positioned appropriately and the cap is fit in snugly. And also to ensure that the circuit is monitored in such a way that appropriate temperature is being delivered to the baby, which is at a temperature of 36.5 degrees Celsius and above with 100% relative humidity. It is also to be ensured that adequate water is filled in the water trap, and it is ensured that there is no humidification along the inspiratory circuit. When it comes to monitoring of the system, one needs to monitor that the set flow, FiO2, as well as the pressure are appropriate and are desirable. It is to be ensured that there is continuous appropriate bubbling, which is neither too vigorous nor too soft. And it is also to be ensured that the baby is appropriately positioned with head in the midline with a neck roll if possible to facilitate mild extension of the neck, and appropriate minimal suction must be performed in order to ensure patency of the nostrils. It is very, very important to remember that CPAP use is associated with a risk of causing nasal injury because of the fragile nature of the preterm newborn skin. And there have been various scales and scoring systems that have been designed to identify and classify or grade the severity of nasal injury, as you can appreciate from one of the scoring systems shown here, published in 2017, which classifies grade 1 injury, as seen in the figure on the left side, as intact skin with localized non-blanchable erythema. Grade 2 is partial thickness loss of skin, and grade 3, as seen in the figure on the right extreme, is complete full thickness loss of skin, which is something that is undesirable, and every measure should be taken to prevent nasal injury, to identify nasal injury early, and to take appropriate measures for preventing the progression of nasal injury by use of appropriate humidification, by use of cycling of the CPAP interfaces. Like, for example, if you find that the use of prongs is associated with nasal injury, one could consider cycling from prongs to mask at a periodic interval. And on the contrary, if the use of nasal mask is also associated with some degree of injury to the nasal septum, then one could consider the use of cycling with HHH-FNC or HFNC, which can be used as an interface. Or one could try and use duoderm or the use of skin dressings, which can prevent direct contact of the interface with the infant's skin. Some of these include cannulates, which are now available in various sizes and can be used as a kind of skin bridge between the fragile skin and the nasal interface. The third important facet of the care of extremely preterm newborns, which we'll be discussing now, includes the early identification and management of a hemodynamically significant duct. Now, as we all are aware, a HSPDA or a hemodynamically significant PDA is associated with numerous physiological effects on the preterm newborn, which are usually arising out of pulmonary overcirculation or systemic undercirculation. Pulmonary overcirculation is associated with increase in the risk of pulmonary edema and alveolar protein leakage. Both of these can result in prolonged dependency on ventilation or respiratory support, resulting in decrease in lung complaints, culminating in chronic lung disease. And systemic hypoperfusion can deplete the gut and the kidney of sufficient blood circulation and can result in low cardiac output as well as end organ hypoperfusion, resulting in various morbidities such as necrotizing enterocolitis, intraventricular hemorrhage, and periventricular leukomalacia. The identification of HSPDA in targeted bedside functional echocardiography includes the measurement of the absolute size of the ductus arteriosus, which is possible in the 2D echo by choosing the appropriate window. Usually the short axis parasternal view or the ductal view is used for measurement of the ductus size. And the other characteristics of the duct, which include the characteristics that describe the effect of pulmonary overcirculation in the form of left atrial to aortic root ratio, LA by AVO ratio, increased in the left pulmonary artery diastolic velocity, mitral E by A ratio, as well as LV function. And some measures of the assessment of systemic hypoperfusion as measured by the Doppler assessment of the vessels from the celiac and superior mesenteric axis, as well as post-ductal aortic blood flow pattern. So this is the classical ductal view wherein we can identify the tripod sign characterized by the three important offshoots here, the right and the left pulmonary artery arising from the main pulmonary artery, and the PDA that is seen here at the end. When you put the color Doppler, you will be able to identify a typical left to right shunting PDA with a red color jet that signifies blood flow from the aorta into the main pulmonary artery, but it is preferable to use the 2D view for measurement of the ductal size at the pulmonary end usually, and a size which is more than 1.5 millimeters is usually taken as a significant sized duct. But it is not just the size that matters, but also the other characteristics of the PDA that we have already discussed that actually are taken into consideration to decide whether a PDA requires treatment or not. So this is the PDA, as you can see, the ductal view or the tripod view, which is of 1.6 millimeters in size. The other important parameters that are often used are the LA by AVO ratio, which is measured in the parasternal M mode axis. The left atrial root, which is measured, left atrial dimension measured at end systole divided by the aortic diameter measured in the end diastole is used for calculating this index. And LA by AVO ratio more than, again, 1.4 to 1.5 is taken as indicative of a PDA resulting in left heart, significant left heart, left atrial, left ventricular dilatation. Flow patterns of significance, which can be used to understand whether a PDA is significant, include the presence of an unrestricted pulsatile flow with velocity which is less than 1 meters per second, which is usually seen in a large and hemodynamically significant PDA, whereas an unrestricted pulsatile flow with velocity between 1.5 to 2 meters per second is usually a sign of a moderately significant PDA. Now, having identified a hemodynamically significant PDA and the other signs of a HSPDA, how does one decide whether to treat the PDA or to just tolerate the PDA as has been recommended by some groups? Now, most people believe that all babies who are small, who are immature, less than 26 weeks and less than 750 grams in birth weight, and in the first 12 hours of life, it may make some sense to begin early prophylactic treatment in these babies who are at highest risk and who are at highest vulnerability to develop complications due to HSPDA, such as pulmonary hemorrhage, intraventricular hemorrhage, and NEC, etc. Whereas in newborns between 26 to 28 weeks of gestational age with a PDA which is sized more than 1.6 millimeters, after the first 72 hours of postnatal age may benefit from an early targeted approach where one may want to treat only those neonates which have clear-cut echocardiographic evidence of a HSPDA accompanied by clinically symptomatic PDA. And in most neonates beyond 28 weeks of gestational age with clinical signs of volume overload such as increase in the requirement of mean airway pressure, increase in the need for FiO2 after initial recovery from RDS, or newborns with hemodynamic instability requiring inotropes, which is attributable due to PDA, or significant feeding intolerance, which is preventing the escalation of feeding, one may consider treating symptomatic PDAs in newborns born more than 28 weeks of gestational age. We shall now move on to the fourth aspect, which includes challenges in optimizing nutrition in this vulnerable group. We know that when we discuss about extremely preterm neonates between the gestational ages of 24 to 28 weeks of gestational age, most of these newborns are born with limited nutritional reserve. The calorie reserve that is present when such a baby is born is usually around 200 to 400 kilocalories, which can only sustain the baby's calorie or metabolic requirement for maybe around 48 to 72 hours, if not provided additional calories and proteins in whatever route might be possible. They also are challenged by immature metabolic pathways involving the metabolism of glucose and protein because of the inherent deficiency of some enzymes needed for gluconeogenesis and glycogenolysis, and because of the relative depletion of substrates, increased nutrient demands because of sickness, insensible water losses and catabolism, and higher risk of medical and surgical problems, particularly because of necrotizing enterocolitis, infections, and evolving bronchopulmonary dysplasia. And one also needs to consider the fact that they have been deprived of the most fastest rate of the phase of in-uterine growth accretion, wherein a baby who is a fetus between 23 to 27 weeks would have actually accreted 21 grams per kg per day or 15 grams per day. This generally slows down to around 12 grams per kg per day by the time the fetus reaches 35 to 37 weeks of gestational age. So when the baby is born preterm, the baby is deprived of this most important crucial phase of in utero growth. Combined with these physiological challenges in optimizing nutrition, there are also practical challenges in the form of non-availability of parenteral nutrition solutions, the exorbitant cost, and the limitations in vascular access, fear of infections, which sometimes kind of limit the use of central venous lines, umbilical venous lines, which can be used for delivering total parenteral nutrition. And when it comes to the practical challenges in enteral nutrition, there are so many variations in practices, controversial guidelines, unavailability of breast milk, particularly in units dealing with outborn babies, the limited number of human milk banks that are available, use of unfortified milk, which can provide very limited volume of macro and micronutrients, feeding intolerance, lack of standardized guidelines for the initiation and escalation of feeds. So one of the important ways to optimize nutrition, particularly enteral nutrition, can be following a very standard and a uniform enteral nutrition policy, which can be unit specific, which should deal with when to start minimal enteral nutrition, how much to start and how often to escalate, and how much to escalate in every 24-hour period. So in our unit, we try to have a policy wherein every newborn, irrespective of the gestational age and the birth weight, should be started on minimal enteral nutrition by 24 hours of postnatal age, provided the baby is clinically stable. And in the babies between 1,000 to 1,500 grams, MEN should be started as early as possible, not waiting until even 24 hours, should be started as soon as the baby's respiratory support has been optimized. Typically, we start with 10 to 15 ml per kg per day in newborns below 1000 grams and with 20 ml per kg per day in newborns more than 28 weeks and more than 1000 grams birth weight. And escalation of minimal enteral feeding should be initiated as early as 24 hours in the more mature newborns and between 24 to 48 hours in the newborns that are born below 1000 grams. And based on the studies that talk about escalation or advancement of feeding, it has been seen that it is generally safe to escalate or progress advanced enteral feeding at the rate of 30 ml per kg per day in most preterm neonates, unless and until there is a contraindication. The frequency of feeding can be 2 hourly in babies below 1000 grams, and in newborns with birth weights beyond 1000 to 50 grams, the frequency can be 2 to 3 hourly, and both advantages are found to be physiologically similar. So when it comes to total parenteral nutrition for extremely preterm neonates, it has been seen that following an aggressive parenteral nutrition approach by providing maximal possible calories and protein has been found to result in better nitrogen retention and a much shorter time to reach even full enteral nutrition. So this is something that needs to be followed. This is based on a study published in Indian Pediatrics by Dr. Umesh Vaidya and team. Now, the preparation of total parenteral nutrition is something that needs to be undertaken in a aseptic manner in complete sterile precautions under a laminar flow, as can be seen in this picture. This is generally prepared by two personnel, one doctor and one nurse. That's the routine practice in our unit. So the doctor is in complete scrubs, including caps and mask with gloves, and is preparing the parenteral nutrition solution within the laminar flow system. And the TPN hence prepared is wrapped in the silver foil, metal foils, is particularly the lipid solution, and then this is brought and connected to the central line of the newborn. Moving on to the fifth important aspect of care, which is to prevent hospital-acquired infections after taking all the precautions for providing optimal delivery room care, for non-invasive support, for the optimal identification and management of a hemodynamically significant duct, and for providing optimal enteral and parenteral nutrition. One should not actually kind of miss the bus by ending up with a hospital-acquired infection, and hence this important aspect. So to understand the aspects of CLABSI, one needs to understand that CLABSI is generally acquired by one of the three routes, which is acquisition of infection from the skin because of inadequate skin asepsis, or it could be the infusate itself. Now, steps to prevent CLABSI include good skin preparation with the use of 2.5% chlorhexidine solution, which is the specially available skin scrub solution, draping with the use of 4 sterile towels, ensuring that maximum surface area of the baby is draped, and daily inspection of the PICC line dressing site, and immediate changing of the dressing once we find that it has been soiled. So this is semi-permeable transparent dressing is used for covering the PICC line site, and the dressing should be changed immediately once detected that it is soiled. Maintenance bundles for central lines are also important, which include covering the site with a transparent dressing as discussed, and replacing dressings every 2 days for gauze dressings, and at least once in 7 days for transparent dressings, or whenever the dressing is found to be visibly soiled. Preparation of parenteral nutrition as well as IV fluid solutions must be something that is a 2% job and should be undertaken with all sterile precautions, preferably in the laminar flow. And care of access sites with the scrub the hub technique is also something that is preferable. One needs to have an exclusive medication area for storing all the parenteral solution, and this should be different from the fridge that is used for storing breast milk or vaccines, etc. Central line maintenance is also something that is carefully undertaken with daily scrubbing of the hub and daily inspection of the dressing. So we also try to have a checklist for central line insertion, which includes various aspects like careful selection of site, pre-measurement of the length of the line to be inserted, and the performer and the assistant wearing complete cap, mask, and scrubs, as well as gloves. and complete preparation of the skin site using the triple swab technique of spirit, followed by betadine and followed by spirit, or triple swabbing using chlorhexidine, complete draping of the site, and inserting cannula followed by passing of the guide wire if a Seldinger technique is used, or direct insertion of the central line, removal of the guide wire followed by checking of backflow and fixing the line at an appropriate length. This is the ANTT or aseptic no-touch technique for peripheral line care. We also follow the VAP bundle when it comes to maintenance of the ventilator-associated pneumonia bundle, which includes head and elevation suction that should be performed carefully with 2 persons, ensuring that the duration of ventilation is kept to as minimal duration as possible. When it comes to the supplies that should be available for the ventilated baby, every ventilated baby must have a complete set of supplies that includes the shoulder rolls, sterile gloves, suction catheters, and baby sheets, endotracheal tubes, as well as ambu bag with a mask as well as reservoir, and no sharing of these disposables must be permitted between the babies. Ventilation can actually be harmful if appropriate humidification is not being performed, and this is possible by a servo-controlled heater humidifier, which allows the delivery of inspiratory gases at 37 degrees Celsius and 100% relative humidity, and no condensation is to be seen in the inspiratory limb, and any condensate in the expiratory limb must be immediately drained. It is preferable to use an endotracheal identifier card for every ventilated baby. As you can see, this immediately gives us in one look the date of tube insertion, the position where the tube has been fixed, and the endotracheal size, tube size. It is preferable to use tubes that are horizontally placed in priority, in preference over tubes that are vertically placed, and this is the suction checklist. So we discussed about the use of VAP bundles, and this picture shows a baby that is comfortably nested and on respiratory support. So having discussed the aspects of prevention of infections, we move on to the last aspect, but also one of the most important aspects of care of the preterm neonates in the form of human milk feeding. So wherever possible, the World Health Organization recommends that mother's own milk must be used for feeding preterm neonates. And in settings where this is not possible, one opts for the use of donor-expressed breast milk, which is to be used with appropriate milk banking facilities that are available. And this may be followed if both these options are not available by the use of either standard or enriched infant formula. Now, the NNF-CPG also has recently endorsed that the mother's own milk is strongly recommended for feeding the low birth weight infant, and this is remembering the fact that specific nutrient supplementation needs to be made in preterm low birth weight needs in infants, because mother's own milk may be deficient relatively in some of the macro and micronutrients, and this can be met by adding a multi-component fortifier in the form of human milk fortifier. Whenever mother's own milk is not available, pasteurized donor human milk from a human milk bank can be used for feeding low birth weight infants. The benefits of PHGM over formula milk include neurodevelopmental disability that can be lesser. So as can be seen from the table, 73 per 1,000 in those babies that are fed with donated breast milk versus 88 per 1,000 in babies that are fed with formula milk. The use of pasteurized human donor milk over formula milk is also associated with a significantly lower incidence of necrotizing enterocolitis and late onset sepsis. So Human Milk Bank is a comprehensive program that includes a lactation support center, wherein all mothers are provided organized lactation support and encouraged to provide on-demand feeding and early initiation of breastfeeding. Breastfeeding counseling is also provided to pregnant women right from the antenatal phase. This is clubbed with a program which facilitates donation of human milk whenever mother's own milk is unavailable, and all such donors are screened for eligibility based on standardized checklist, and it is ensured that mothers are free from viral infections such as human immunodeficiency virus and hepatitis B before being eligible for donation. Milk hence pooled is then subjected to pasteurization by the Holder technique, which is followed by quality control mechanisms, including among the human milk culture, and milk hence pasteurized is and found to be free of contamination is then frozen and awaits the requirement in the NICU when it is subjected to thawing process and then is dispensed for a needy baby in the NICU. The use of human milk is also something that that has been found to reduce the use of the incidence of necrotizing enterocolitis. And while talking about NEC, one of the other important aspects of our understanding in the pathogenesis of an NEC has been the understanding of the gut microbiome pattern, wherein the normal human microbiome, which in a breast milk fed baby may be predominant with bifidobacterium. It has been found that in babies who are vulnerable to necrotizing enterocolitis may become predominated by organisms like firmicutes and enterobacteriaceae. It has been seen that the human milk microbiological pattern may underlie the predisposition for a number of adult onset diseases, including allergic conditions, celiac disease, and other problems, including even predisposition to certain malignancies, etc. So it has been seen that probiotics or the organisms that are found to confer some health benefits in the host do so by a number of mechanisms of action, which include maintenance of the mucosal barrier integrity, regulation of appropriate bacterial colonization, and modulation of intestinal inflammation, as well as activation of general intestinal immune defenses. So when we take up mucosal barrier integrity as a function, it has been found that probiotics strengthen tight junctions and inhibit bacterial translocation, and hence strengthen the mucosal barrier integrity. They also modulate the growth of appropriate bacteria by producing substances that can be toxic to aerobic bacteria and by reducing the intraluminal pH and by offering competitive exclusion from the gut binding sites. Probiotics are also found to modulate intestinal inflammation by increased production of anti-inflammatory cytokines and decreased production of pro-inflammatory cytokines, and activate the intestinal immune defense mechanism by increased fecal IgA production. When it comes to the evidence on the use of probiotics, a systematic review of studies from low and middle income countries did demonstrate that there was a substantial and significant reduction in the incidence of late onset sepsis, all-cause mortality, and necrotizing enterocolitis with the use of probiotics. And some specific recommendations are now available based on the evidence that has been seen, that a combination of probiotics, including at least one strain of lactobacillus and bifidobacterium each, is found to be more preferable over single strain probiotics. And the dose that is recommended is 3 into 10 to the power of 9 organisms or 3 billion organisms per day, preferably given as a single dose. This is to be started whenever the baby is ready for enteral feeding, preferably within the first 7 days of life, and is to be continued until 35 weeks of corrected age or until discharge. In our unit, we are using probiotics for neonates that are born below 1,250 grams, and we only use in neonates between 1,250 to 1,500 grams if they have abnormal Dopplers. At present, we are using single-strain probiotic in the form of Bifidobacterium breve M16V strain. This is being provided in the dose of 0.5 sachets twice daily until a feeding volume of 5 ml, followed by 1 sachet twice daily beyond a feeding volume of 5 ml. So to summarize, we have so far discussed 6 important domains of care of extremely preterm neonates, starting from the delivery care bundle, the use of non-invasive ventilation, the early identification and management of a hemodynamically significant PDA, optimizing enteral parenteral nutrition, the implementation of bundles and packages of care for prevention of hospital-acquired infections, and the use of mother's own milk feeding and probiotics for preventing NEC. We would also be glad to share our short-term outcomes of extremely preterm neonates born between 23 and 27 weeks of gestational age, wherein we have seen that the most common morbidities are respiratory distress syndrome, up to 82% of babies, followed by IVH and NEC. We had 33% mortality in this group, which translate into a survival of around 67%, which is comparable with most other centers in this group of neonates. These are some of the babies who have got discharged from the unit. And I thank you all for joining today's session. And if there are any questions, please feel free to drop them in the comment section in YouTube or in the chat box in Zoom. And thank you all for joining.